Good morning, everybody. Thank you for showing up today for the Health and Human Services Committee, and I guess, Paul, Madam Clerk, would you please call the roll?
Alderwoman Spencer.
Present.
Alderwoman Ingracia.
Present.
Alderwoman Tyus.
Present.
Alderwoman Green. Alderwoman Martin. Alderwoman Navarro.
Present.
Alderwoman Middlebrook. Alderwoman Rice.
Present.
Alderman Todd.
Present.
Chairman Ornowitz.
Present.
7 present, you have quorum.
Thank you, Madam Chairman. And I believe the first order of business will be, we have to make a motion to approve the minutes from last meeting.
We approved the minutes from the previous meeting.
Second.
Previous roll.
Was there a roll?
Wait,
It was only the,
wait, I know, but, well, yeah, can you do previous roll from the roll call?
not for the
No,
roll.
oh, that's right, we haven't
roll
done.
call.
Yeah, we have to
Would you
vote.
please call the roll?
Alderwoman Spencer.
Aye.
Alderwoman Ingracia.
Aye.
Alderwoman Tyus.
Aye.
Alderwoman Green. Alderwoman Martin. Alderwoman Navarro.
Aye.
Alderwoman Middlebrook. Alderwoman Rice.
Aye.
Alderman Todd.
Aye.
Chairman Ornowitz.
Aye.
7 aye votes.
Thank you, Madam. And just so it's noted, Alderwoman Green, Martin, and Middlebrook are excused for today. Thank you. So the reason we're meeting this morning is I got in touch with Mr. Craig Smith, and I know his department has been working with St. Louis County this summer over some different programs. So I wanted to ask everyone to come down and let us know and keep us in the loop of what programs you've been working on. So, Mr. Smith, if you want to step up, and the gentleman and 2 ladies, if you are going to speak when you come up, we should have a sign-in sheet. Okay? So, thank you.
Mr. Chairman, members of the committee, good morning, and thank you very much for the opportunity. So St. Louis City and St. Louis County share a vision that we've developed, which is not yet achieved, but it's St. Louis, an equitable community achieving optimal health for all. All St. Louisans are able to achieve their best health, and our mission in the city Department of Health is we assure a healthy St. Louis through quality public health services and partnerships. One of those key partnerships, because we only have 87 employees and we can't cover everything in the city, obviously, is that we work with partners including St. Louis County. So there's lots of things that we could go over, but I know that there's a lot of things that aldermen need to do. So we want to talk briefly and just give you sort of an idea of some of the things. So if we can, we're going to go just a couple minutes over most of these items, and then a longer period of time over the Community Health Improvement Plan, which is specific issues that I know would be of concern to alder people and to your constituents. So we have some of our colleagues here from St. Louis County Department of Public Health, whom I know you will welcome. We have Paula Sutherland, if you'd raise your hand. And Emily Varner isn't here yet, but we're hopeful that she'll be here shortly. And Hannah Kramer. And then there's a couple people from the City of St. Louis Department of Health, myself, Michelle Bildner, and Bobby Williams. So the items that we want to cover today are the Recast grant in North City and North County, in the Promise Zone, Prescription Drug Monitoring Program, the Academic Health Department, a little bit about Tobacco 21, and then the Community Health Improvement Plan, and then questions, if we could, at the end. So hopefully all of you have a copy of this. The clerk has that. If you need more copies.
I think this is, are you going to?
Which one is third? This one or this one? The whole.
This is a PowerPoint. So Bobby Williams is going to come up here and tell you a little bit about the CDC 1817, which is on chronic disease. Here's a couple minutes.
And if you don't mind, just state your name and where you're employed at.
Yes, sir. So my name is Bobby Williams. Good morning to everyone. I work for the City of St. Louis Department of Health, and specifically in women, children, and adolescent health, or sometimes it's referred to as family, community, school health. And so today I just want to give you a little bit of an update about CDC 1817 grant that is a joint or collaborative effort between St. Louis City and St. Louis County. Also involved in this collaborative group is also the Missouri Department of Health and Senior Services, the YMCA, SLU, WashU, Affinia Healthcare, People's Health Centers, Family Care Health Centers, and Integrated Health Network as outlined on your second slide. As everyone knows, diabetes is a huge problem within our country, unfortunately. Depending on what poll you look at, it's either the 6th or the 7th leading killer of U.S. citizens. So we wanted to create an effort to address that within our communities. We thought it would be best if we did a joint effort with the city and the county, seeing how people are transient, no one lives or stays within their specific zip code. And so this approach really looks at a all-encompassing attack on diabetes. We want to make sure that we focus on key factors such as medication compliance. We want to make sure we focus on access to health care, food access, and also activity, physical activity, and also as well as awareness or education with our residents. So this particular grant has afforded us the opportunity to come together once again and to really key in on those specific items. We are now in our second fiscal year of the program, and we are ensuring that we are linear in our approach and connected so that we're all saying the same thing, we're presenting the same thing, and we're referring the same way, so it's not to confuse our residents as they are introduced into the program. Program focuses a lot on what I like to refer to as many of us say in public health, a strength-based approach. So we have community health workers that are involved in this. Community health workers are more of a peer resource so that an individual doesn't feel less inclined to open up and talk about their current health condition, as they may, the white coat fear, as some refer to it as. And these individuals they go through a uniform educational system that we've created with St. Louis Community College, these community health workers, and they are actually members of the communities that we're targeting specifically, as everyone is aware of the promise zones, where the rates are even higher than what they are. St. Louis rates are already high as it is. So Missouri rates are higher than the national average. St. Louis rates are higher than the Missouri rate, and then in the promise zones, we know they're up to 2-3 times worse than what they are in as far as St. Louis City as a whole, or surrounding communities. So it's nice to have peer support that are located within these communities so that it gives us our message more credibility and also a greater level of understanding with our residents that we're trying to target. In addition to diabetes, we're also addressing cardiovascular disease, stroke, and also heart attacks. We know that's the number one killer in the world, so it's important that we address those as well. Does anyone have any questions?
Let me ask the committee, we can ask questions after each person is fine with me, so, we'll go down the list. Alderwoman Spencer?
Thank you, Mr. Chairman, and thank you for being here today, Bobby.
Yes,
I
ma'am.
haven't met you before, but appreciate your service to the city. You mentioned the rates being significantly higher in the Promise Zone. I represent the 20th Ward, which has extremely high rates across the board, and we're not included in the Promise Zone, much to my dismay and consternation. Can you speak to that specifically, because it's my understanding that the 20th Ward and our neighborhoods in the south part of St. Louis have rates just as high, if not higher, than many of the Promise Zone neighborhoods.
Yes,
And
ma'am. Definitely. So that's a very good question. So with our efforts, so some of our efforts include food desert areas, are addressing the lack of access to wholesome goods. So we're actually using some of our funding to bring mobile markets to locations so that wholesome groceries can be purchased by the residents. So South St. Louis, for instance, we have both the Link Market and the Metro Market that attends Affinia over at Limp off of Gravois, so that anyone can take advantage of those services. So the services that we have in the program are not just limited to the residents in the Promise Zones, but
I mean,
access to them.
that's wonderful. I mean, I'm familiar with Link Market. I know the folks who run that, and familiar with Metro Market as well. But this is the first I've ever heard of them offering anything close to the Limp facility.
Oh, yeah. Yes, ma'am. Yeah.
Has that been in place for a long time, or, I mean, are we doing any outreach on that particular offering, or?
Yes, ma'am.
Okay.
So we've advertised through flyers, Affinia Healthcare over at the Limp location. They've also advertised those services. Metro Market, they're there. They've been there. We're in October. Wow, time's flying. We're in October already. They've been there, I want to say, at least since August of this year. And then the Link Market, we've had Link Market there since around the mid part of September.
Okay, I appreciate that. It's the first I've heard of it, so I appreciate that. And I apologize if I've missed a memo on that.
So, Bobby, just a quick question. So aldermen are aware if in fact in their wards they have these outlets for outreach for food and things like that?
If they're not, we'll work on getting that
Could you let
information
the
out.
alderpersons, if you can give them something that way, they can
On that.
make it public in their ward if they like. Anything else?
No, well, I would just like to, reiterate the high rates being in Dutchtown, Gravois Park, and while the Affinia location at Gravois at Limp, I'm not sure exactly where you're talking about specifically, the Gravois Affinia
Yes, ma'am.
at 55 maybe, and
So yes, right, exactly, where Highway 55 and Gravois meet, that
Okay.
Limp, or the Affinia Healthcare location right there.
Okay, that is located maybe a half a mile south of downtown and at least 3 miles from Gravois Park. And so it's not really serving the community there. In fact, there are several grocery stores in between that high need zone and that high density zone of Gravois Park, Dutchtown, and this potential offering. If there's a way to include offerings like this within the actual high need zone, I think that would be much more beneficial to the community that needs it.
Yes, ma'am. I'll definitely be in contact with you.
That sounds great.
We're going into our fiscal year too, October 1.
And we have an
Right.
Affinia in Marine Villa right across from the Gravois Park Dutchtown area, which may be a better fit. It's along Jefferson. It has a high visibility and that sort of thing. But it is in an actual food desert, whereas the Affinia you just described is maybe 2 blocks from a grocery store. But I really do appreciate this particular, this type of outreach. I think it's very beneficial, and I'd like to work with you to make sure that the community that I serve is served by this.
Will do.
Appreciate it. Thank you.
Thank you.
Anything else? Good. Next, the Honorable Alderwoman Ingracia.
Thanks so much for your time today. Can you clear up, I just didn't hear correctly, you work predominantly with women, children, and families?
That's right. So our bureau at the Department of Health is called Women, Children, Adolescent Health, but
Oh,
it's
adolescent.
here in City Hall, it's known as Family, Community, School Health, and we actually work with the male aspect of the family as well. We have a whole men's health program that we focus on as well.
Okay, and so that's your department under the health department?
Right, that's my section. Yes, ma'am.
Okay, all right, and yeah, just to echo the Alderwoman from the 20th sentiment, I would love to know more about when these markets are certain places so that I can get that information out to my residents. And is there the ability to request if there are areas that we know are experiencing issues with accessible food?
So 1817 federal grant is, so it's all specified within the write-up for the grant, competitive grants. So we have to make sure that we're servicing the zip codes that we identified within the grant, which had the highest need overall, which went into the research that we did before.
What are those zip codes?
So they're the problem zone zip codes.
Oh,
So,
okay.
yes, ma'am, they're exactly the problem zone zip codes.
Okay.
Yes, ma'am.
Is there any conversation about trying to expand the program to other areas that have need?
Yes, ma'am, and of course, so with all grants, the goal is so after the grant funding has dried up, that we have some ways to sustain the services and even expand the service, so we are definitely looking into that
Okay,
during the program.
thanks for your work. It's
Yes, ma'am.
important, and I appreciate it.
Thank you.
Thank you. Alderwoman Tyus?
Thank you, Mr. Chairman. Mr. Williams, did you say that here in City Hall, you're known, because I heard you say women and children and adolescent health, but you're known as the Family Community Food Health? Is that what you
Oh,
said?
no, family, community, school health.
School health,
Right,
okay.
family, community, school health.
All right.
Right.
You didn't put the Promise Zone in place, right? That's a federal program that was put in place. Is that correct?
So the promise zones, of course, were the zones that were identified through research collaborative work with the city, the county, and academia.
But it's a federal program.
Yes, ma'am, right.
Right,
yeah.
okay. And so the research that was done about the food deserts and things like that, I'm pretty lucky in North St. Louis because I put my whole political career on the line, and I actually have a grocery store and a Walgreens and everything else, but not, I went through 2 recalls about doing that, okay? So, and I know that they closed all those grocery stores down to have mine. So they closed 5 grocery stores in North St. Louis so that we could have the one at Union and Natural Bridge. And I begged Craig Snooks not to do that. Literally sat in the leisure room and said, this is a bad idea. He said, but you're gonna have one. And me having one doesn't make up for the 5 and really they closed 7. That's really sad for me because now people are waking up to the fact about food deserts and also the prominence of diabetes in many African American communities. And we have fast food, we have no sit-down restaurants, we don't have healthy food. And I've been fighting that since I first got here. When you say that you do community outreach, what kind of things do you do? And also, did you send us, because sometimes things get by us, did you send us like emails when things were going on and saying, hey, this is happening? Have you been doing that? Or were we getting it in our box and we just missed it?
So let me answer the first question. So when we do outreach, what we're doing is we are actually utilizing that federally qualified health centers that are part of the group. And also the YMCA, they're also an integral partner of this. And we are using outreach, first of all, targeting the patients that they already have, that they've already identified as being type 2, suffering from type 2 diabetes. Because the
Right.
program is focused on type 2 diabetes. We know that that's 95%, only 5% is type 1 diabetes. And then with that, so the focus of the program is to get individuals enrolled in life-changing programs, which is the buzz phrase the CDC uses. So those life-changing programs, a person has to be at a certain mental state to commit to a life change. I mean, I don't know if anyone here is a fan of Oprah. I am. So, Oprah talks about life changes or like that. Well, you have to get an individual to that state where they are ready for a life change. Otherwise, you're spinning the wheels. They're going to recess and nothing's going to get done. So that's why we're really focused on the FQHCs. The question was, are we looking to expand the program? We are. But first, we have to, get, as our former director said, we have to get the low-hanging fruit. We have to get the easy wins to show that we are successful. And then we will be able to expand to a broader audience outside of the FQHCs. Now, we are also in the City Department of Health, when we do our outreach normally in the community, we are asking people as they come by our tables and to our outreach events, hey, are you suffering from type 2 diabetes? Are you a pre-diabetic? Or do you have a primary care physician? Because research has shown people who have primary care physicians tend to do better in life-changing programs. If they answer all that, yes to that, and they're interested in signing up for the program, we do register them for the program, and then we send that information on to the YMCA, who's actually the facilitator of our diabetes life change program. So that's the form of outreach that we're currently doing right now, but we are looking to expand it, as I said earlier, once we get those easy wins and we've established a protocol for the program. Your second question was, how do we advertise it out? I would make sure whatever we have in the past that we send it out
Digital,
Yeah,
I think, works
that's
for
not-
mostly everybody here. I don't need the paper. Paper is, it gets in my way, but if you send me something digital, I see it pretty fast, okay?
Yes.
Sharon Tyus, TYUS. But I think mostly that, not just for me, for everybody here. I don't think most people want paper. My other question was, would you be open to coming to a meeting if we had a meeting about health? You know, maybe a joint meeting with several wards about health care, about what the health department does. If not you, I know, is Craig here? Okay.
Yep.
Is that something that you would be open to?
The department is always looking for opportunities to do that, Alderwoman.
Okay, thank you. Can you tell me anything you think that I could do as an alderperson to better help you do what you do?
Yes, ma'am. Just so awareness, really. Awareness huge. So we know about 1 out of 10 U.S. residents are walking around that are identified individuals of having type 2 diabetes. But you know, there are reports out there that are about 84 other million that are pre-diabetic. If left untreated, they'll become diabetic within the next 5 years. So I mean, we have this huge subsection of our population. They're just not aware. So awareness is a huge thing. That's what I mean. What is it? So I said 1 out of 10. I think reports are saying by 2050, if things continue the way they're going, that maybe 1 out of 5, so double, or up to 1 out of 3 will be diabetic by 2050. So that's one awareness.
So, and also, when you get these studies and positions, do you share them with other departments? Early in my career, I tried to stop a Taco Bell going up on Natural Bridge. And the reason why is because we have so much fast food, and I knew about the diabetes and things like that. I'm like, we don't need another fast food. We need healthy food. And so I wish you would share this with like the Board of Public Service and Board of Adjustment, because they don't even seem to understand and care about health issues, okay? They just, a business wants to go here. It's a business, boom. And so I wish you all would have this conversation. I guess it's also for the director to let them know that there are bigger things than just putting a business in. Because if you go on Natural Bridge and Kings Highway, which I represent, you got White Castles, burger, everything, fast food heaven, okay? So that's I call it diabetes lane. I try to stay away from it. I don't eat there very often. I meet with the people there, the business people there, but it's not a place I try to hang out. So I would hope that you guys would share this with the other departments and so that they could understand health is so important. My last question for you is, this bus that goes around, are you familiar with that? I think.
Right. So there's actually two. So there's Metro Market and then there's the Link Market.
Okay.
So Link Market was actually the same person created them both. So Dr. Jeremy Goss, he was the one that actually created Metro Market with 2 constituents. He then left Metro Market and created Link Market. Well, I can't say on his own because he did the first one on his own too, but he brought in 2 partners. But he also now is the entrepreneur of Link Market.
And my question would be, is there a way that we as alder people can maybe help them to expand that?
No, definitely. That's
Okay.
I will be in
All right.
contact. That's fine.
If you would let me know which way, because it's not just about for my questions, it's for community surrounding me. Because as I said, I do have grocery stores pretty near me, but the community surrounding me are food deserts. And if there's a way we could help expand it north, south, wherever that needs it, that would be wonderful to me, because I got a chance to buy from the Metro bus when President Clinton was here and he was in the 4th Ward, and I went there and I just bought up all kind of vegetables and fruits, pretty reasonable.
Yes,
and
ma'am.
if we could expand that, that would be great.
Yes, ma'am.
Thank you, Mr. Chairman.
Thank you, Alderwoman. Alderwoman Navarro,
I have no questions, but thank you very much for being here.
Alderwoman Rice,
Also no questions, but thank you for being here.
Thank you.
Alderman Todd,
Do you have after-school programs for kids as well as weekend programs? Because, you know, in the public school and summer programs in the public schools, they eat breakfast and lunch.
Right.
But then they don't eat after. Apparently, they go hungry the other times. So do you have programs like that for the kids and families?
Yes, sir. Our 1817 grant is focused specifically on the issue of diabetes, also with an association from our 1815 grant, which is focused on hypertension. But we do have programs at large underneath our health and nutrition section of our department that does focus on after-school programs and also nutrition in the schools. I'm actually part of another collaborative group called Healthy Schools, Healthy Communities, and they do a lot also with MCE, Missouri Coalition for the Environment, and they focus a lot on schools, nutrition, and activity as far as exercise for young people and obesity rates with young people.
Okay, thank you.
Yes, sir.
Any follow-up questions? Mr. Williams, thank you very much for your time.
Mr. Chairman, that was your first 2-minute presentation.
That's fine.
And appreciate the shout out to MCE. How about that? Alderwoman, I did want to mention this, and we made a note specifically of the health and all policies. That is something that we're very committed to. Sometimes other departments are committed to that as well. It's kind of a change in thinking, but definitely on that.
If you come to the, I know you, because you've been an alderperson, but I want to say that I know that if you come to the BPS or Board of Adjustments,
Right.
they just okay any old crazy
Do they
thing.
now?
Yeah, they do.
I know. Yeah.
Okay, and they're not, they don't look at the health benefits,
Yeah.
We got 20 fast foods, let's have 22 fast foods. Oh,
So this
that's
is,
not a great thing.
it's a gradual process, and hopefully we'll be in a position over time. I know the director's interested in trying to make sure people are equipped to make those kind of decisions. So the next presentation is on Recast, Resiliency in Communities After Stress and Trauma, and it's Paula Sutherland, and she'll try to keep it to 2 minutes, but obviously wants to answer your questions as well.
Good morning.
Morning.
So Recast stands for Resiliency in Communities After Stress and Trauma. Resiliency in Communities After Stress and Trauma. We were awarded this grant from SAMHSA, the Substance Abuse and Mental Health Service Administration, in 2016. We just wrapped up our 3rd year. We're beginning our 4th year. And so the packet that you have in front of you is a combination of results from our 1st and 2nd and 3rd year, as well as what's going on right now. So you mentioned our target area is a promise zone. I'm familiar with that. 28 North County municipalities, 11 North City wards. We award projects in the areas of violence prevention, peer support, mental health, and youth engagement. And so we use participatory budgeting process to do that. And that includes recruiting residents that live in the Promise Zone that are at least 11 years of age or older. They help us come up with the scope project ideas that St. Louis County turns into an RFP for the scope of work. We issue those RFPs out. Those responses that we receive back, our community members then come help us review those RFPs, those proposals, and then we put those RFPs out for our community vote. We are doing that right now, this particular week, and so we've sent out information. We have newspaper advertisements, radio commercials, where we're trying to get community members to come out and vote on, we call it community projects for well-being. And so, again, this is our 3rd time actually doing that. The 1st year we did award projects for grants for $137,000. We had 4 recipients. The 2nd year, we did mini grants. Our community delegates said that they wanted something more our non-traditional grassroots organizations could be a part of, things that were closer to the neighborhoods. And so we did mini grants for $20,000. In year three, we renewed the large grants from year 1, and so this year we are awarding 4 contracts of $75,000 in each one of those funding priority areas. What we realized after our 1st year was the community members comes up with the project ideas, and that's, to us, that's empowerment. Instead of us going in and telling them this is what you need, you tell us what you want and what you would support. And so as a result of that we give the community what they need, but obviously we had to develop a needs assessment and a strategic plan before we started awarding money. And so we recognize that sometimes those community projects don't help us meet our strategic needs. And so we do a gap inventory where we actually look at what projects have been awarded and what what other areas we still need to address. And so the first 2 years, we had carryover funds where we were able to award some other projects with those dollars based on what we saw missing out of our gap inventory. And the last thing I'll say, this is a partnership with St. Louis County, St. Louis City, and the St. Louis Mental Health Board. And then, again, on your second slide, again, our community voting is going on right now. We'll be at Ferguson Library this afternoon. Tomorrow, we'll be at North County Transit Center, and Friday, we'll be at the University City Public Library, and then on Saturday, we'll be at the O'Fallon Recreation Center. And so the packet of information that you have actually shows the number of community members that we've been engaged in over these first 3 years, as well as the impact that the projects that we have awarded have resulted in. And that's all I have. Is there any other questions?
Alderwoman Spencer.
Thank you, Mr. Chairman. And I have a feeling that we're going to be talking a lot about the Promise Zone here today. And as somebody who represents the area with the highest concentration of youth in the entire city, Gravois Park, Dutchtown, and a high level of stress and trauma, crime, and other activity, it is my sincere hope that we look at expanding these services and outreach to areas outside of the Promise Zone that also have a significant amount of stress and trauma, especially when we're talking about a lot of children, and children specifically living in poverty who experience stress and trauma and have no resources currently to deal with those issues. Are we implementing any programming outside of the Promise Zone?
So we're not implementing any programming outside of the Promise Zone, but the organization that we have awarded, I would like to think that we're paying, they have these services already, and we're paying for the services for those individuals that live in the Promise Zone, which opens up spots for other individuals. For instance, St. Louis Artworks, that is a known organization that provides youth apprenticeships. They have spots specifically for Promise Zone individuals, so that's 20 more spots or 40 more slots that they could actually give to other individuals for their programming. So no, we're not necessarily targeting anyone outside of the Promise Zone. Like Bobby, that is a federally designated area that was identified for our grant when we submitted the application, so those are the boundaries. But again, out of our programs, we do not tell people they can't offer services to individuals in those areas, and they probably do. We just can't fund those specific activities.
I understand, and I'll just reiterate that I'm available to partner on ways to expand types of services in areas outside of the Promise Zone that have extremely high levels of need, specifically in the areas that we're targeting here. So thank you I really do appreciate the grant and this outreach, particularly in the Promise Zone, and just hope we can find ways of providing value and providing resources to those high need areas outside of it.
Thank you.
Thank you, Mr. Chairman.
Thank you, Alderwoman. Alderwoman Gracia.
Thank you. I appreciate you undertaking participatory budgeting. I think that is a really smart way to engage and empower communities. I did that in my ward when I first got down here, and everyone thought I was crazy, except my residents.
I think it was your example that we followed. Spring Schmidt is a member of your community.
Yeah. Is there a list somewhere online that we can look at what projects you've already worked on? I'd just kind of be interested in seeing what the community comes up with.
So the packet that you have has the year 2 funded projects as well as the year 3
great.
funded projects. So they're all listed here.
Perfect.
But we do have a website, a Facebook page, as well as Instagram. And so you can, and the information, locations are there.
Okay. And you said that people can be delegates if they're 11 or older?
11 years of age or older, as well as vote.
Yes. Right. How many, do you know offhand about how many kids you have as delegates?
So we have this little page right here that actually shows you what we've been able to do as far as the age-wise. And so, okay, does it say kids? 42 of our delegates have been between the ages of 11 and 24.
Wow.
And we want to increase that. We really, really want to increase that.
Yeah, that's awesome. Thank you so much.
Thank you, Alderwoman. Alderwoman Tyler.
Good morning.
Good morning.
Thank you for the work you do. I just have really a request. I know I've been following it for the last 3 years. I would love to see you move the voting to different places sometime. I know it's been at Deaconess and it's been at O'Fallon. That makes it, you know, unless you put people in a car sometimes and take them over, it makes it a little hard. I would like to suggest Matthew Dickey as an alternative. And is there a reason why they're just at those same places? Because they've been there.
So we've actually used different locations every time we voted. There are some that we've done repeatedly. We did
Deaconess.
O'Fallon Rec Center.
Right.
In year 1. We didn't in year 2. We did it we're doing it now. This is the first time we've been at Deaconess. And so we've actually tried to do 3 county locations, 3 city locations.
Right.
The issue that we have, we actually can't secure our locations until after we receive the RFPs, because the very first year, we set up our community voting, and then we received our RFPs and realized that 3 of the people that were actually going to be on our ballot. So we can't do the voting locations until literally after we receive the RFPs and determine who moves forward. And so we're open. If you know of a place that we can utilize, we just try to position them throughout
I
the
understand.
promise zone.
But I'm just saying, I would love to see like Julia Davis Library or Matthew Dickey, both of which you can get. I know you can get them. And that brings in another group of people, short of me just putting all my constituents in my car and taking them to vote. Okay, I'm trying not to do the weighted voting
Right.
thing, but if you move them around, I know
Yeah,
people like to.
we're
right.
welcome to any
Okay.
suggestions.
I
We've
can
actually
help you
been at
get those
Julia Davis
locations pretty
location,
easy.
and that was actually great. But again, the problem is, because we have such a short window
I
when we're
understand.
going to do it, when we call, they're not necessarily available. You know, I mean, because trust me, Julia Davis was a great location.
Okay, and the other thing is that since some of my people did not get to Deaconess, they can go over to O'Fallon.
They could go any place,
They can go to any
They
of these
could
places
go
as
to
long
any
as they live
location.
in the promised zone.
just as long as they live in the promise zone.
Okay, okay, so that's great.
And I want to
know.
add that the project proposals are on our website, and so this is the first time this is the second time we've done this, but we're really pushing it, because obviously when you go to vote, normally you are an informed voter, and because we are mixing up very legal procurement processes with community engagement, there's only so much that we can do, but you can go read the project descriptions on our website and pick the projects, your ballot, who you want to vote for, so that when you come into the poll, you don't have to spend time reading the abstracts.
And you just have to have some kind of ID to show where you live?
We ask you, where do you live?
Don't even have to have an ID?
No. We're
Okay.
tracking, we're doing address verification, and so I verify that that address is in the promise zone. We're actually keeping that information so that we'll know that there's not duplicates. We are taking the names of individuals so that there aren't duplicates. But we're trying to kind of eliminate the barrier. You do not have to be a registered
You want to
voter.
eliminate barriers from voting? No, that's
Well,
progressive of you.
well,
My goodness, we really just have to put you out of business. I'm sorry.
no, I mean, ideally, and what we really like about it and why we really want young people to be involved is that, you vote.
I know.
In this case, you vote in October, and you should see that project in place by December, January, so that your very quick results, you see what the results of your vote immediately, or quickly, anyway.
Thank you very much. I appreciate your program. I have no further questions.
Thank you, Alderwoman. Alderwoman Navarro.
Thank you. There's a lot of great data here, a lot of good numbers, and I'm curious if these also track to any particular health outcomes. And I don't know if that's required in if the grant requires you to track, the engagement numbers, but also if there are health outcomes that you also track along with those.
I would say we're not tracking them to any health outcomes, because again, they're youth engagement, peer support, mental health, and violence prevention. And so there's not necessarily health. When we conducted our needs assessment, we obviously identified that there were some food deserts and some other issues regarding food, but unfortunately, that is not the focus of our grant. And so it may be an offside benefit that's a part of it. When we have our community delegates meet, one of the barriers that we do, we provide them with snacks and food. There's some of the, I know some of our youth providers obviously do the exact same thing. I know our peer support provider, which was CHIPS, they have the peer support group which is around diabetes and other health issues. So we don't necessarily do it purposely, but it is an offset or benefit of some of the services that we're providing.
So in terms of like substance abuse and mental health, which is part of the recast, right? That's what.
Well, that's through
those are
the
services
organizations
that
that we
provided.
receive the funding for. That is not our focus. Again, it's youth engagement, mental health, peer support,
Okay.
and violence prevention.
Okay, well, are there any, are there any particular outcomes or success stories as a result of these grants that you'd like that you can share with us? You know, something that you can point to and say, hey, after 4 years, this is just your chance to brag about something that's come out of these years of funding.
And so we have recently contracted with St. Louis University to do our local evaluation of our program. And so they are kind of capturing that information from the grant itself. I just can't specifically think of any story, but we will actually have that information, and I can actually send that information to you.
That would be great.
Yep.
Great, thank you.
Okay, thank you, Alderwoman Navarro. Alderwoman Rice.
Thank you so much. I'm glad that my colleague asked the question about IDs, because that was going to be a question as well, especially because it's a federal grant. I didn't know if you were having to verify that those, that the kids are living where they say they're living and that kind of thing. So I'm glad that that's just verification that the address is within the zone and they can access these programs and to vote. That's great. As far as, and this is sort of a broader Promise Zone grant question, and if Craig needs to jump in, fine. But you sound like you know what you're talking about here, so I'm going to ask. If this is a limited 5-year grant, what happens at the end of this, right? And health departments are run on a lot of outside grant funding, and it sounds like you've got a really good thing going here. What are we looking at after year 5 at this point?
So when St. Louis was awarded the contract, we were one of 8 cities that received it because of communities that had experienced some kind of trauma. Since then, SAMHSA has awarded 2 more recipients, obviously because there continues to be communities that are experiencing trauma, but they've awarded 2 more cities each time. They have not said anything about the continuation of this grant after year 5-year program. And so this was actually Senator Blunt's. He was the one that authored this actual program. So they haven't said anything about what happens, but what I will say is that we have numerous organizations. The Missouri Foundation for Health is on our core advisory board. Children's Service Fund is on our community advisory board, and United Way. Those organizations are looking at what we're doing with our participatory budgeting and considering implementing some of that in their programming. And so as far as ourselves, we do not have any way to sustain this funding past year 5, but there are other funding organizations that are participating in it that are looking at what we do.
Okay. And so this was, each year was a 4.7 million, or total of the 5 years?
Total of the 5 years.
You got the 4.7,
Yeah, so
okay.
each year we award about almost $500,000
Okay.
that we give out.
I mean, you're doing a lot with a little bit of money, and that's great.
Thank you.
I'm just sort of, it's one of those frustrating points for me that this is one of those things that we should be pouring money into, and the fact that you're having to rely on grants and the instability of those is difficult. So I commend you all for your work with this, and hopefully we can get together with some other folks and find some more money for programs like this. So thank you.
Thank you.
Alderman Todd.
I don't have any comments.
Ms. Sutherland.
Yes, I got married. It was Hughes. You said you remember me. Right? It was Hughes
I
before.
do remember you. I want to thank you for your time, and you've been very helpful and
thank
informative
you.
for us.
I do want to add, if we can come to any Alderman meetings to tell them about Recast. Michelle Mitchell is our Community Engagement Coordinator. We've been trying, we've been to many, and we would like to continue to do more, because again, we do this process every year. The community delegates are new. We try to expose it to more different people every year, and so we have 2 more years. Thank
Okay,
you.
thank you.
Mr. Chairman, members of the committee, so I wanted to reflect on a couple of things. One is in terms of success stories, and I know that it's not news to Alderwoman Spencer or to Alderwoman Ingracia because you all have done this, but the very fact that you have governments changing their process in terms of requests for proposals and allowing people to vote on these things where normally it's just a closed, seemingly like closed process in terms of how these things happen. So the community decides what's going to go into that community, which is very empowering. That's one of the issues in terms of regaining control after trauma and so forth. So this area after Michael Brown, August 9, 2014, it's one of the reasons why this grant is just perfect for this community. And I also wanted to reflect, I understand that we're talking about the Promise Zone. It has 199,000 people. It would be helpful, obviously, if it could have been extended. When you're working with St. Louis City and St. Louis County, Skinker is sort of our dividing line, so it's a perfect kind of scenario to kind of look at how we can work together. And later on, you're going to be hearing about these equity issues with our Community Health Improvement Plan. It really hits those. Should it be hitting the southeastern part of our city? Well, you know where I stand on that. Clearly, it should, but we definitely need to make sure that we're making a difference in these areas as well. This next program, the Prescription Drug Monitoring Program, there's a Prescription Drug Monitoring Program in Guam. There is not a statewide, Missouri is the only state that doesn't have a prescription drug monitoring program, but St. Louis County and St. Louis City participates in this. So, and that does cover the entire city. So if we could have Emily Varner come up, that would be helpful. And she'll also give the 2-minute presentation.
Try to keep it short and sweet. I have handouts. Sorry, I didn't get these out in advance. But I'm Emily with St. Louis County Department of Public Health, and I'll talk to you a little bit quickly about the PDMP. So as Craig mentioned, Missouri does not have a statewide program. We are the only state in the country without a statewide program, but that hasn't stopped us from creating a PDMP. So in 2016, the county passed legislation. The city was next in line. The city passed legislation a couple of months after the county, and you guys were second to join. So thank you for joining. You helped get this going in the state, and you guys were number 2. The program itself launched in April of 2017, so we're about 2.5 years old, and we have grown from when we started 14 jurisdictions to 75 now. So this map covers or outlines what jurisdictions are and aren't participating. The darkest color green are the ones that joined us in 2017. So that's the city, the county, St. Charles, and so on. There were quite a few jurisdictions that joined us in 2017. The medium colors kind of 2018, and the light green are the jurisdictions that joined this year in 2019. So that's what the PDMP kind of looks like in terms of participation. With these 75 jurisdictions, we cover 85% of the state's population. So while we're not incorporating or covering the entire state, we do cover the majority of the state. And the PDMP itself kind of has 3 goals. 1 is to improve prescribing, 2 is to inform clinical practice, and then 3, kind of our long-term ultimate goal, is to reduce the number of people who are misusing, abusing, or overdosing from drugs. PDMP contains information on controlled substance prescriptions, so schedules 2 through 4, that are dispensed out of any of these jurisdictions. So that's opioids, that's painkillers, that's benzodiazepines, muscle relaxants, stimulants. Any controlled substance that is dispensed out is reported into the PDMP. What we do with that information is, first and foremost, we make this a clinical tool for healthcare. So we make that information available to healthcare providers. They can do what we call a patient search, so they can review their patient's complete prescription history and use that to inform clinical care. So they know what their patient has received, what's been filled, so they're not prescribing something that will create a dangerous drug combination or put their patient at risk for a negative drug interaction. But that way they know what they have, what they don't have, and they can make more informed clinical care decisions. That's the ultimate goal of the PDMP, or the main focus. We do take some of that information and report out in aggregate to our stakeholders. So the stapled kind of packet is one of our quarterly reports. It's Q2 of 2019, and it's specifically for the city. The front page outlines, here's all of the users that we have in the whole system. Its majority is healthcare provider, less than 1% is kind of non-healthcare. And then the back side is, here's a map, and you can look at prescribing rates, and it's St. Louis City numbers in particular. So we do release these out every quarter to all of our partners, and they are jurisdiction specific. So the city gets a city report every quarter, the county has a county report, and then every year we do a lengthier annual report. All of this information is online. The other piece, this does cover the entire city. It covers the majority of the state. And this is currently at no cost to the city. We did receive, like the previous presenters, lots of federal funding. We have a Department of Justice grant or secured DOJ funding that covers all of the participating jurisdictions. So everybody but the county gets DOJ funding for this. I think that's trying to keep it short and sweet. That's all I have.
Thank you. Alderwoman Spencer, you have any questions?
Thank you, Mr. Chairman. So when we're monitoring the prescriptions, and we see a problem, you know, a particular physician, for example, or a particular patient, what is the action that is being taken to address overprescribing these medications?
Yes, so what we will be rolling out in December of this month, or what we're calling, or this year, prescribing summaries, and those are individual clinician reports on their prescribing behaviors. So prior to the prescribing summaries, clinicians really have no idea of how their prescribing compares to their peers. Are they overprescribing, underprescribing? So they'll be receiving these prescribing summaries that tell them, here's what you are doing, you yourself as a provider, compared to other providers like you. So we'll compare dentists to dentists and pediatricians to pediatricians and so on. And then here's kind of that comparison to the system. With that, there's specific educational materials. So if you're a risky prescriber or a bit of a concerning prescriber, here's the things that we want you to know that you need to know about this, some ways that you can improve your prescribing behavior. So those will be rolling out in December to the clinicians so that they know how their prescribing practices compare, and then what they can do to make changes if needed.
And are we doing anything for individuals who are, for example, are we monitoring individuals who are maybe using
Doctor
multiple-
shoppers?
Yes.
So
To offer resources to individuals who may have a problem?
So in the PDMP, there is an alert that is the multiple provider alert that clinicians can see if their patient has gone to multiple providers and multiple pharmacies. Then there's different resources in there so that the clinicians, like if they see that alert, here's the recommendation. Don't just kind of kick your patient out and say, you're not my problem. Here are resources if you need to assess them for substance use disorder, if you are considering being a treatment provider, here's what you need to know, here's some resources for patients, and kind of connecting them out with resources.
And if we do identify clinicians who, for example, are taking advantage of individuals who are doctor shoppers, for example, kind of shopping around and, looking the other way, it's my understanding that that does happen, that there are doctors and clinicians who are known to overprescribe and be okay with prescribing, knowing that there are other doctors prescribing the same patient. What actions are we able to take in those cases, and if we're identifying those?
Yes, so we have the legal authority to notify licensing, regulatory, and law enforcement agencies under suspicion of a reasonable belief of a breach in professional standards.
Sure.
So that is, we have the authority to do that. I will tell you, prior to these prescribing summaries, we have not been able or haven't used the data in that way. The focus has been we're relatively young still, we're under 3 years old. The focus has been getting this system up and running for healthcare, making sure the information in there is right and accurate and the pharmacies are participating, and then getting healthcare providers to use it. Now that we're moving into prescribing summaries, we will know or have looked at the data in a way that we can identify these riskier providers. So we're working and having lots of conversations with the licensing boards and like DEA and the controlled substance authorities to see what and how we want to proceed in that. We are public health, so we're not that licensing regulatory agency, and we don't want to scare providers into not treating patients that need to be treated. And so we're very cautiously kind of getting into this space. With the prescribing summaries, our first round will be really focusing on education. So if you are one of those riskier prescribers, a lot of providers, they're not bad. They don't know that they're kind of heavy-handed in their prescribing, that, oh, I didn't know that, like most, I don't know, general practice, internal medicine providers, like, I didn't know it's not normal that you don't just write an opioid script to every patient that comes through your door. So we're kind of taking the education approach of, here's where you fall in comparison to your peers. Here's some recommended behavior changes and things that you need to know. If there are certainly some really egregious providers, then we'll coordinate with the appropriate agencies for kind of them to take action, because that's not our space as public health to investigate and to take like regulatory action.
Sure, and I really appreciate that approach. It's my understanding that St. Louis continues to see a rise in opioid overdose deaths, as opposed to, which is contrary to the national averages, which tend to be going downward. What other steps can this legislative body take to help protect our citizens? We did pass the PDMP ordinance 3 years ago, or maybe 2 years ago now, I think it was three. What other actions can we take to better protect our citizens and help facilitate the work you're doing?
Yeah, so I would say kind of anything that's kind of this well-rounded, holistic approach. The PDMP is a great tool, but it's not a silver bullet to solve this problem. It's really a prevention tool, so preventing additional people from developing substance use disorder and then overdosing and having the additional ramifications. So supporting and your local health department in harm reduction and overdose, naloxone, treatment resources, kind of anything you guys can do to support the kind of, after the prevention stage, continue to support PDMP in the prevention stage, but then beyond that, once you're past the point of preventing someone from developing substance use disorder, then supporting all of those additional pieces. So naloxone, harm reduction, treatment's a huge issue in the region. We don't have enough treatment resources, and treatment's expensive, but beyond like medical care, what else do you need to live? You need housing, you need food, you need transportation. So kind of any of those, well-rounded approach that, what are the basic life needs of anyone, but particularly individuals with substance use disorder.
That's all I have, Mr. Chairman. Thank you for your service.
Thank you. Alderwoman Gracia?
Thank you. Do you feel like you have an adequate budget to undertake the work that you think would make you operate at the highest level of quality?
For the PDMP? Yes. I think we've been really intentional at the county. We have secured a substantial amount of DOJ funds to support all of these activities. I think public health is across the board just really underfunded, and kind of beyond the PDMP space in treatment, in harm reduction, and recovery, and in kind of all of these, we're talking about food, we're talking about transportation, we're talking about housing, like we're underfunded across the board. I think PDMP, we're pretty well set there because we have received the federal funds to do that. But I don't want to speak and say that we're all well funded. I think that the county health department can always use more money, and the city health department can always use more money. So no, public health is not well-funded across the board.
Yeah, no, I completely agree, and I was just with specificity, making sure you felt like you had adequate money to operate. Are there examples, I'm assuming our programs are so new in Missouri, are there examples of how this is really making an effective change in other places, and how are we studying that here?
Yeah, so PDMPs have existed for over 100 years in the U.S. So they're not a new thing. They're new to a handful of states. We're one of them. But they're not a new thing. And the challenge with PDMPs is when PDMPs were started, they were not with a public health approach. They were a law enforcement approach. So the majority of PDMPs were founded out of a law enforcement or licensing or regulatory agency. So their job was really to make sure that the doctors and the pharmacies were prescribing and filling what they should be doing. There's kind of what we consider the new wave of PDMPs, where they've either moved from that law enforcement realm into public health or have just started out of public health. So depending on which PDMP you talk to and you ask, the metrics are different. The things that we track for our system to kind of show the impact with a public health lens is how many providers do we have registered with the system, and are they using it? Yes, our ultimate long-term goal is to reduce the number of people who are misusing, abusing, and overdosing. It took us many, many years to get to where we're at now, and so it's going to take us many, many years to start to see a measurable decline. So looking at, we've had a huge increase in the number of providers. We now have over 15,000, close to 16,000 healthcare providers registered with the system. That's huge. We're doing about 7,000 to 8,000 patient searches a day, so providers are using the system, they have accounts, so we're really focusing on kind of increasing that access and then usage of the system.
You said 6,000 to 7,000 a day?
7,000 to 8,000. I think we closed out September at about 7,700 searches a day with about 15,500 providers.
Wow. Okay, thank you. I appreciate the work. It's needed in St. Louis for sure.
Thank you, Alderwoman. Alderwoman Tyler.
This thing. Good morning, how are you?
Good, how are you?
I'm fine. And so, Ms. Varner, you're with the St. Louis County Department of Health, or what's your title?
I'm the Substance Use Program Manager.
Substance
there.
use, so that covers more than just opioids?
Yes.
Okay. First of all, I'm going to talk about opioids, then I have a statement to make. When I look at the map that you presented to us, it is a shame that we don't have a statewide law. It's embarrassing. When you look at 75% participating jurisdiction, 85% of the population, and the places that are not participating are not big, huge parts of this state, it indicates what is happening with redistricting over the years, that there are certain Republican government can control the whole state and really do harm to our community. I think this is shameful. I was just asking our chairperson if we could, as a group, send a resolution to the state and to our state reps, asking them to please ask them to pass this law statewide. I mean, this is ridiculous. So I hear a lot about it. I have a friend, Joe Palm, that works
DHSS.
out in the
Yep.
field all the time. So I hear about this all the time and things that are going on. And Joe is really adamant about public health and public safety being tied in together. But I do want to say this, and so this is a little off. I love how you treat opioids. I wish you would have, I wish not you personally, but the people who are in public health would have treated cocaine and crack the same way. It is such a different way that they have treated it. Even separating out crack to say that you have harsher punishments. So in my community where crack has been in many parts of it, or cocaine, it is troubling for them to hear how you humanize people who use opioids, because they're mostly Caucasians originally, and you demonized people who used crack as though it was not, and not you, I'm not saying you personally.
No, the system
The
has.
system, that's
Yes.
what would be a better right. You demonized people, and you had things like crack holes, crack babies, and all of that, when in fact, all of it is, when you are hooked on a substance, that's a substance abuse and should be treated under public health, not criminally. And so I just want to kind of ask you, is there things that are there any kind of programs that you have besides opioids, which you are very careful to treat? Because I think, and I will say this, is because the people who are helping to push these things, some of their children are involved, and so they see the child next door, and they don't see the other children next door who are, I don't have any children, but all these other children are my children next door, so are there other programs?
Yes and no. So non-alcohol and non-opioid-based addiction is incredibly challenging to treat because we are relatively fortunate in alcohol and opioids that there are medicines that we can use to treat these diseases. You have methadone, you have buprenorphine, you have Vivitrol. There are approved meds out there that we can use to treat addiction, if it's alcohol or if it's opioids. There are no drugs out there to treat stimulant, meth addiction, cocaine, marijuana. If you want to kind of throw anything out there besides opioids and alcohol, there are not meds for that. So that makes it much more challenging to treat that because the treatment is cold turkey. You put somebody through withdrawal and you try to work with them so that when they have urges to use or they're being triggered, that they can work through those and not use drugs. The other really challenging piece is we have Narcan or naloxone, and it's a wonderful drug that can reverse an overdose. It only works for opioids. There is nothing out there to reverse a cocaine overdose. So we're limited in the resources that we have. There is no kind of magic bullet special drug to treat other addictions. So it's kind of
We the other two people.
getting our foot in the door and getting providers comfortable and trying to see opioid use addiction or opioid use disorder and alcohol as people and being comfortable treating that part of addiction can kind of help open the door to other areas of addiction as well.
Well, I think if we even soften the conversation, okay, so, and in opioid treatment, you don't, yes, the medicine is there, but there's other further backup treatment besides that, right?
Yep.
But I think that when you humanize people instead of demonize people, you get a different result already,
Absolutely.
okay? So when you're demonizing it and you're making 3 strikes and you're out and all of that kind of stuff that we've done under Democratic presidents, that's why you get such a harsh look at it. And people didn't think that their children, although their children, and then to separate crack and cocaine, to separate sugar and powdered sugar, right? So that's why you get that kind of result and separate it out by race and things like that. So I would love to just hear people in health community humanizing other people that are using different kind of drugs, be it alcohol. I've never known anybody who abused marijuana, but okay.
Right, I'm like, talking drugs, that's always
I
like,
know, but I'm
that's
just
not
saying.
really, but,
I've never known that. Even in college with all my friends to do, I don't get the same results. So I don't put marijuana with alcohol and the rest of the things, okay? And we're gonna pretty soon legalize marijuana, and we're gonna have to really take a step
be a
back
whole nother
on
can
that.
of worms, yeah.
Right, but just to, if I could just hear it from all parts of the health community,
Absolutely.
starting to humanize people and stop demonizing them, that would help. I have no further questions.
Thank you, Alderwoman. Alderwoman Navarro?
Thank you. I just have a question about, I guess, yeah, your measurable outcomes, and I understand you're still kind of in this first phase. You've just got to gather this data. But are there long-term measurable goals for your purpose, reducing the number of people who misuse, abuse, or overdose, informing clinical practice? Are there long-term goals that you're hoping to shoot for kind of in the next phase, I guess?
So really long-term, driving down some of the death rates or seeing the number of people that are dying due to drugs decrease. Some of the pieces that we are looking at on kind of a shorter, long-term are the number of prescriptions that are being written or being filled, and then looking at some dosage and days supply. So are we still writing a lot of really high-dose, long-term prescriptions that are putting people at risk for developing dependency and then addiction and substance use disorder, or are we more appropriately prescribing for like acute pain? If you have a tooth pulled, you don't need a 30-day supply of hydrocodone, you need at most 3 days. I could argue you most likely don't even need that. You need some Tylenol or ibuprofen. So some of those cases that we're looking at of our dosage, duration, number of scripts, it's hard because you'll never get to zero. There will always be a reason to have prescriptions, and we don't know what our kind of sweet spot or what our number is. A lot of states have seen a marked decrease in the number of prescriptions that are being written, but a still increase in the number of deaths. So forcing or reducing the prescription supply is causing some individuals to have to go to the illicit supply because they have legitimate pain or chronic medical care that they're not able to get from a healthcare provider. So we're trying to figure out, and we'll continue to try to figure out like what our goal is in terms of number of scripts that are needed to appropriately treat our population, but dosage and the length of a prescription or how many days you're getting meds for are two of the things that we're kind of tracking as well.
Thank you. I don't have any further questions.
Thank you. Alderwoman.
Thanks. That was exactly what I was going to ask about, was how do, we have people who do actually still need medication for pain, and how do we route them to the correct places and that they're able to access it without being demonized, without, suspicion, but, and then not lead them towards illicit sources for these things. So thank you so much for your work, and thank you for also clarifying that, we're a health approach versus a law enforcement approach, I think is good. So maybe in one instance, it's better that we were on the later wave of the PDMPs, that we can learn from some mistakes and implement this well. So thank you.
Thank you, Alderman. Alderman Todd?
I would just like to reiterate what the alderwoman from the first ward said. My question is, since this has happened to black people, crack cocaine, and white people, fentanyl, which is 50 times stronger than the street heroin, which was identified with black people. My question is, are you all going to work on educating people and also reparation and letting the people go, advocating that these parents and many people in the prison who are black with all these long terms get out of jail so they can be with their loved ones? That's the only way to solve that problem, is educate people about what is going on instead of, again, sweeping it under the rug and prettifying it, because these are real people who are suffering.
Yeah, so I think across the city and the county and across the state, there are some different communication and public awareness campaigns to, one, raise awareness that this is an issue, here's what's happening. At the state level, I think the site's No Mo Deaths, and they really hit hard on the disparities and how we kind of swept this under the rug and ignored it until this was an issue in the white community, and they've been pretty bold in splitting out, here are the issues that the racial disparities that we're seeing. And then in the city and the county, that we've been focusing and targeting some of our education and outreach in high burden communities. So we look at what zip codes, or kind of break down like overdose deaths by zip code, and then we're targeting our high burden zip codes, which are primarily North St. Louis and kind of South St. Louis. If you kind of throw race in there, it's North St. Louis is where the majority of our African-American population are dying from overdose deaths, and then South is the white population. And so we're working in kind of those two areas with different messages, because we've heard from the community that there are different kind of concerns and feedback. And so some of the messages in North St. Louis are that treatment's available. Treatment's available for you in particular, because we've heard from the community, well, treatment's now available because white people are dying, but treatment's not available for me. And so telling them what specific treatment, where they can go for treatment, what resources are available within those communities, within North St. Louis. Narcan works, or naloxone works on all opioids. Heroin, fentanyl, it's important to have. There are lots of different types of treatment, so whatever treatment you want, what treatment works for you. It's your treatment. That there are resources, there's treatment, there's resources available for you, and then we've kind of done that with a geographic or a community-specific lens. So we're directing people to resources in South St. Louis to resources in South St. Louis and north to north, so that they know what their local options are. And beyond that, there's lots of efforts. I can't speak to the criminal justice system and what changes might be happening in the criminal justice system, but from a public health perspective, we certainly support and recognize those disparities and would love to see some changes in that.
Good, thank you.
Thank you, Alderman. I want to thank you for coming down today and giving us a great update on things. We really do much appreciate it.
Thank you.
Mr. Chairman, members of the committee, so one thing that I wanted to mention is the question was asked about certain things that might be done to try to help with this issue, and I know you know a lot of them. So just advising and informing, as you know, we're likely to get another syringe access program bill. Probably Holly Rader will introduce that again. So harm reduction, looking at those kind of things. Expansion of Medicaid could have an influence on a lot of these things that are going on, and of course, you've already identified that the statewide prescription drug monitoring program could be very helpful as well. Also, I know that the director is working on any number of things related to substance use in general. We are very clear that it's not just about opioids. Opioids tends to be what is being funded by the federal government. We know that a lot of bad decisions were made in the past in terms of how we treat individuals with regard to these substance use disorders, and so we're all about trying to have that public health approach, and very happy to work together with legislators and others to try to make that happen. So expect that the director is likely to be coming back to you to look at some of those things as well. I did want to quickly go over a couple a couple of these. So the Academic Health Department, we came to you before because obviously we need to make sure that we're getting approval when we accept money. So there is a partnership with the SLU College for Public Health and Social Justice, St. Louis City Department of Health, and St. Louis County Department of Public Health. It's a best practice effort. It brings together the academic institutions who are really good at that research side, evaluation side, together with the folks who are out there in the community working on a lot of these public health issues. So it's a benefit both to the institution academically as well as to our public health departments, kind of creating some of that infrastructure. So I outlined, once again, because I think most of you were here for that, but making sure that you have that information, that the Missouri Foundation for Health is supporting that through a grant over the next, now it's 2 years because we've gone through most of this first year. And it kind of outlines how we've set that up in terms of the steering committee and the Teaching and Workforce Committee and the Research and Policy Committee and some of the other aspects to that as well. And then I wanted to touch briefly as well, because I know there's a lot of issue in terms of vaping and so forth, that the city and county work together on Tobacco 21. Those ordinances, both in St. Louis County and St. Louis City, prohibit the sales of both. They're both considered tobacco products, both cigarettes as well as vaping products. And it's illegal to sell those in either the city or the county to anyone under the age of 21. We're in evidence, we are evidence-based departments, and so we certainly look at those kind of things. I believe there's something like 21 deaths that the CDC believes may be related to vaping related products. I shared with the that shared this morning, and I don't think this is any special news, that there's something like 500,000 deaths per year that are considered to be related to tobacco in this country. It is unclear at this point. The FDA does not regulate what goes into that juice for the e-cigarettes and so forth. And so those are things that certainly the FDA, CDC, and others are looking at, and we try to monitor that. I know that at least one of our epidemiologists is clearly looking at that now. Are there questions about that? Otherwise, we could go into that community health improvement plan, which is a critical piece, I think, for what we're doing today.
No.
Okay, so we have Michelle Bildner and Hannah Kramer, who are here to talk to you about the community health improvement plan, and this is the first ever that we've done with city and county in our public health system. So we're very pleased about this, and we know that there's thousands of people working on this, and you're part of the local public health system, and all of your constituents are as well. So thank you.
Thank you.
I have to check the time. I can still say good morning.
Barely. Got 30 seconds.
Michelle Bildner with the City of St. Louis Department of Health, live in the 13th Ward.
Hannah Kramer, St. Louis County Department of Public Health.
So I want to echo what Craig said. The slide pack that you have demonstrates that this is the first ever collaboration between two jurisdictions, specifically St. Louis County and St. Louis City in our region, to work on a shared strategic assessment and planning process for community health. But in addition to what's presented, we also have our hospital system partners at the table as well. Logistically, we're required to conduct these activities in terms of accreditation and gold standards and best practice. The hospital systems are also required to do a similar process. Different timeframes, different cycles, but same partners. And so this is the first time that we really convened across those tables. Through our assessment process, which took approximately a year, we convened over 150 different unique individuals from 50 unique organizations or more. So we're very intentional about collecting data at the population level. So those outcome data that some of the other people were talking about, as well as community engagement and input, and not just feedback. We also looked at our local health system in general. So that includes, of course, decision makers, academia, educational institutions, nonprofits, private organizations, different business sectors, and then we always would love to see other parts of government at the table for those planning and recreation and other kinds of decisions, but we'll get there, right? So that's what's really important. As a segue between this assessment process and moving into where we then use that data to drive decisions for planning, we also convened around a shared dashboard that is public facing, so that anyone in the community who may be at that small scale organization, as Paula was talking about, if they're putting together a needs assessment or want to look at specific data pieces on a community at the zip code level, depending on how the data is collected, we collaborated and fund that dashboard, thinkhealthstl.org. So that's just something to really highlight, because it also showcases this work. It showcases the assessment work that's been done, as well as the plans that have been developed by our community partners. So it's a wonderful clearinghouse of information. I believe September 12th, we hosted a large event at 1520 Market. Everyone was invited from this committee. Thank you, Alderwoman Rice, for showing up. And for those of you who couldn't make it, we do have some orientation and some video pieces that might be great to share with you. I recognize we did not do that, but the content of that event is in this program, so you've got some highlights. So we'll spend a little time talking about the structure of how this all kind of works and how we're really doing this together. And I'll let Hannah talk about that. But if you want to point, if you want to point to maybe page 5 of the booklet, we'll look at this framework.
Great, so the partnership came together, and the way that they wanted to structure coming out of the assessment phase into the planning phase was around 3 priority areas. So if you look at the top of this structure, you'll see we have 3 priority areas that guide all of our work. So the first one is around social determinants of health. I think we all recognize that those touch our residents profoundly. The second area is around health and racial disparity and centering that in all of our work. And then the third is around bolstering our local public health system, because we know we have improvements to make in sort of how we serve our residents' needs. And so the way that we've structured is those three priority areas that are all guided by the vision at the bottom. And then we, as the partnership was moving from the assessment phase into the implementation phase, there was a question of how do we go about doing this work? How do we touch these three priority areas over a 5-year plan that touches both the city and the county? And so the groups involved in the assessment phase decided that they wanted to sort of select these action team areas. So these are core areas that touch all of our priorities, but that really focus around the issues outlined below. So we have improving access to community health. That actually speaks to issues of like access to primary and specialty care as well as behavioral health. Originally, those were siloed as 2 separate groups, but we saw this partnership as an opportunity to bring those camps together, to work together as one group, tackling issues of access that impact both our behavioral health needs and our physical health needs. And so that's that first group in gold. Next, we have sort of this umbrella group around chronic disease. We've taken a very upstream approach to chronic disease because we know that social determinants of health in particular have very consequential impacts on our health outcomes. So what we did with this group in the green is really looking at some of those upstream approaches. So we have a group looking at food access, looking at built environment, looking at youth workforce development, and then looking at early childhood. So really those upstream things, because we know that we need the folks at the front line, and we also need folks working on really upstream strategies to get folks help well before they develop chronic disease. We also have a violence prevention group. We know that that's touching our community very strongly over the summer. And so this is ongoing work. Our maternal, child, and family group was originally put together with sexual health, but we really realized that those 2 groups had their own work to do in their own space and complement one another, but could stand on their own. So this is sort of the current structure. We say that all of this work is living, so we are open to, over the course of the 5 years, making course changes. We saw that with the top group of sort of bringing together sort of an access to care space and behavioral health space. And so you might see some changes as we continue through this process, because as Michelle mentioned, this is our first time doing this with the city and the county at the same table for the plan. So this is sort of the structure. On the sides, you see we have 2 supporting structures. One is the Regional Planning and Leadership Group, and they are a mix of folks who are involved in these action teams directly and also other folks. So we have at that table like the Integrated Health Network, the Regional Health Commission, folks that are intermediaries, folks that represent other sectors that might not traditionally find a space in public health. We welcome all of them to that table. We have our academic institutions, our health institutions. They all have a place in that leadership group. The Community Health Advisor Team was very active during the assessment phase, brought resident voice into that process. And so they haven't met during the assessment phase, but we did convene them as part of our event last month. So we wanted to take a few minutes to walk through some highlights of the different action teams, and also to sort of understand where particular areas of interest might be, so we can connect you with folks leading that work or come back to speak to you at length. So this is sort of a high-level overview, but we welcome additional opportunities to speak more in depth about certain topics. You want to start Match?
Yeah, sure. I'm going to use your deck. So as Hannah mentioned, improving access to community health, MATCH. We love acronyms, but I'll give you the full title. Tandem partnership between the Behavioral Health Network, who is really the convener of different behavioral health agencies so that work on mental health as well as substance use disorder issues, along with the Regional Health Commission. And so the first really success story around those 2 groups is the merging and is the combining of plans and is of using one kind of constituent body to help guide their decisions and be accountable to. So we take those small wins, those process wins, because we know without that shared decision-making, that none of the work will be able to get done. There are plenty of strategies that they're looking at different treatment centers, perhaps, to address some of the concerns that were raised around comprehensive approach to substance use prevention, right? In addition to the PDMP, there's also a strong advocacy for engaging community health workers in the work of clinical care and other health outcomes, and what that looks like at the state level, passing Medicaid, getting CHWs reimbursed, so on and so forth. The next team that we'll illustrate is around infant mortality and maternal, child, and family health. So what's unique about this work is that in the past and across many communities, a community health improvement plan really just lives with the health department. And we're the only ones accountable, and we're the only ones that are answering to the issues. And that's really not even in the name. It's a community health plan. So the strength of this approach is also using existing organizations or partnerships that have a strong focus area in maternal and child health, for example. Generate Health is a great example of that. They're also leading the work in terms of community participation. They have an established community leaders cabinet where they have 40 individuals from residents across the city and county who are trained up in strategic planning and how to implement programs and really voting on that. So we're getting the equity lens through. And each group can serve as a great model for other groups where others might be stronger or weaker. For example, violence prevention, St. Louis Area Violence Prevention Commission, that is a group that was already formed, that was already in the process of developing a strategic plan. They use a public health approach to violence prevention. It'd be great to see the tables turn as we talk about opioid prevention, right? Leaving that public safety sphere and then translating that more into public health and doing a holistic approach. So we're in full support of the VPC's work around those issues. They have strong community engagement tactics as well through canvassing and through other planning bodies. They have 8 subcommittees all the way from youth to evaluation and looking at their work. So we're really proud of that model, that structure that they have in place. We also have a sexual health group that's focused on STIs, HIV, congenital syphilis, comprehensive sexual health education that the state of Missouri is required to implement, medically accurate, and we don't do a good job of that, right? And so this group ranges all the way from health promotion to treatment. So they're across the board, a very heavily provider-focused organization. And so we're also trying to make sure that they're using a public health lens with their work. So we're really lucky that a coalition's at the table for that stir. Do you want to talk about the chronic disease?
So moving over into sort of our umbrella underneath chronic disease, first we have the Built Environment Group. That is sort of one of our newer coalitions that's formed underneath this partnership, which is really fantastic that we're not only supporting the expansion of existing work, but also creating space for other coalitions to form. So this group, I think someone mentioned earlier the need for health in all policies, and they're really, that is sort of at the crux of what they're doing. So they are looking to develop recommendations on how to go about doing that and offer those to officials in the city and the county because they really want health to be infused in all community planning efforts. They're also looking at other policy opportunities, especially around reducing fatalities, street fatalities. So looking at how do we make the physical environment of our streets safer, sidewalks, crossways, and reduce those fatalities. So they're doing an assessment over where hotspots are and looking to make recommendations to our officials on how to make repairs to our streets so that folks aren't dying on the way to school, on the way to work. And so then we move on to food access. So food access is, they also have a really comprehensive approach to addressing issues, especially impacting areas with food deserts. So they're looking at bringing in everything from business owners to farmers to making, to approaching sort of the system as a whole, down from the consumer up to the producer, and looking at how to involve everyone in a process where everybody benefits. So our farmers have a clear pipeline to the consumer, consumer to get high-quality produce and other foods directly into neighborhoods where we're not seeing them. So there's a lot of efforts, a lot of campaigns. If that's an area of interest, we can bring those details that might impact your wards in particular. But it's really, it's looking at the whole system, the whole food system. So that's very encouraging. Next, we have our Youth Workforce Development Group. And so the backbone sort of organization behind that is the St. Louis Regional Youth Employment Coalition. You might have heard of them. They're the ones that the last 2 summers have given Metro cards to young people with summer employment to really reduce any barriers for young people getting job experience over the summer. And so that's one aspect of what they do. They also create pipelines for youth in school and exiting school to employment, vocational, and additional schooling opportunities. So they have a multiple-pronged approach there. And then if we move on to early childhood education, that is Southside Early Childhood Center on Jefferson is the backbone organization for that effort. A core piece of what they've been doing over the last year or so is a landscape assessment, trying to figure out where gaps are in the city and the county for quality early education slots. They just released an incredible report that details that down to just the street level. The maps are very informative, and what they're doing now is looking to base policy recommendations off of those assessment findings, but really the point is not only do we need slots in particular areas, but we need quality slots. What does that look like? What are some standards that we can push forward to improve what kids can access when they can access early childhood education? And so that sort of brings us to the end of this sort of overview piece. We would really welcome any questions on specific areas that we can further connect you to, or just about this partnership as a whole, because we are really excited. This is a very promising step forward for St. Louis, for both of our departments and our partners in doing this work together. So thank you for your time.
Thank you both for being here. This is really inspiring to hear about this combined effort. With that, I'd like to ask or have questions from the committee. Alderwoman Tyus?
Actually, the 6th ward has got seniority.
Oh,
over me.
I'm sorry, you're
That's
right.
all right.
I skipped over. I did. I'm only vice chair here, so please forgive me, Alderwoman.
Thank you for being
Ingracia.
here. This is really exciting. I think the more the city and county can partner together on efforts like this, it just helps us all as a region address the issues that are the same or similar in both places. Please let me know how I can support your work. I'm very interested in participating and learning more about what's going on. I don't have anything today. You didn't really touch on it, but I see that sexual health is one of the action areas, and just curious about what's going on with addressing STIs, where our challenges are, what we can be doing better to hopefully not have such a dubious
High burden.
yeah.
I think stigma is still a big issue and a big concern that STIR and us as working and committing on the CHIP wants to kind of overcome, specifically around LGBTQ plus populations. I know that is a big focus, as well as other minority populations. So stigma is a big piece. And then also making sure that available treatment, prevention treatments such as PrEP and PEP is available, and what that looks like in the community. How is that marketed? How is that communicated? And what the narrative really is around sexual health. We know that individuals will bypass some of our free or reduced cost clinics and still go to the ER for treatment. So we know that something isn't working, right? I know at the health department, we've opened the health stop on the first floor at 1520 so that we do have testing, screening, and treatment available. St. Louis County also operates a sexual health clinic, and the director of that is the director of this coalition. As their plan kind of firms up, there's definitely advocacy efforts around reducing stigma, as well as some legislative pieces. Just thinking through that, we'll keep that in mind. And we also know that this disproportionately affects youth. so age 15 to 24, are suffering from chlamydia and gonorrhea, the highest out of all of our population.
Are you looking at how St. Louis City Public Schools are educating their kids around sexual health?
What we know broadly about the sexual health curriculum is that it's mostly absent in Missouri, as well as, it's complicated with the 23 school districts in the county. But at some point, yes, we hope to dive into that. That is the relationship that we still need to kind of build and bridge, and find out the window of time for that. But it's definitely not out of reach or out of thought. So yeah, thank you for bringing that up.
Sure. Thanks again.
And now for Alderwoman Tyus.
First of all, I want to compliment you on collaborating. How could you do that without changing all the laws in the state of Missouri? I can't imagine that you just picked up the telephone and decided to work together. How did that, could you just please explain to me how that happens without changing every law?
I'm a bit of a hybrid. So I was doing this assessment work as an employee of St. Louis County Department of Public Health. And really, I think it was the previous director at the city and Mr. Schmid here who were really great partners in saying, like, let's stop the madness. But also our partners, the people that we convene over and over again to these assessment meetings and these planning meetings and these conversations, and they kind of said, stop the madness too. So it kind of came from all angles, and it makes the most sense for us to do, and I think we'd already started building that relationship across departments, so it really was a little effortless in a way. The rest of it, the logistics are hairy, but we navigate through that, and it's a learning process.
And there's no laws that prevented you from working together that you found?
No.
Well, the biggest barrier is that our email systems don't work together, and we can't use like a shared Dropbox or things like that. So technical difficulties abound, but there were no barrier
Oh, you mean you don't like to have better together, the freeholders or anything? None of that you need?
I will say also one question that we sort of get regularly is sort of how do we align with our hospital partners their cycle, because as we alluded to, we are on a 5-year cycle. Hospital systems, they have to do this process, the assessment and planning, every 3 years. And so that's an ongoing challenge for us, right? So one way that we've sort of continued to attend to that is through this dashboard. So encouraging hospital partners who not only need their sort of individual site footprint data, but also city or county data to really go to that site, because we know that our community partners have intense assessment fatigue. Our residents certainly do, and so we are looking for opportunities to better share data, better disaggregate, get down to the zip code level, census tract, and so to make that free and available to everybody who needs it, so that we have less burden on our communities and our community partners, even though we still remain on different cycles.
And who created the dashboard? Was it something jointly done with the two, city and county?
Yes.
Yeah,
Okay, and you just kind of worked it out about?
Worked it out. Yeah, the St. Louis Mental Health Board was really a pioneer in getting the dashboard up and running because of the lack of good mental health data in the region. And so they were the catalyst for bringing it forward. I believe county really signed on to that process and had a staff person in place. And then we joined as a city and signed some paperwork, transferred some funds, and now it's being maintained by both of us.
And have you seen any really big, huge differences in the approach from the city and the county? Or
In the
have you
approach?
had any really major differences that you had to work out?
I think there's always adaptive challenges with doing this kind of work. We talked about some of the technical challenges, but we continue to think about this work from a collaborative standpoint. What kind of communication structures are in place? What does decision-making look like? Are we focused on equity? We have to figure it out, right? And so, yeah, there's challenges along the way, but nothing that's prohibited progress or impeded anything.
Well, I really want to compliment you. You ought to leave these jobs and go out on the road to teach other departments in the city and the county how to do this, because we're getting ready to go into a quagmire that I don't really think that we need. when I see people like you doing just what needs to be done, sitting down, working it out. So my hat's off to the health department in both the city and county. And I'm going to give you a shout out on the floor of the Board of Aldermen Friday, because I just think this is wonderful. And thank you so much.
Thank you.
I have no further questions.
Alderwoman Navarro.
Great, thank you, and thank you again for all of your good work. I agree, the collaboration is wonderful. It does make me wonder, or it seems like we're very dependent on a lot of these nonprofits being able to carry out a lot of this work. So I have two questions. One is, do the coordinating bodies here, or any of these participating organizations, do they receive funding for their coordination efforts? And then two, what happens if one of these groups, isn't available? And I'll just, full disclosure, I also work for Missouri Coalition for the Environment, and we convene the Food Policy Coalition. And if the funding would go away for that, I feel like it's going to leave you all in a lurch. So, what happens if one of those groups or convening bodies, can't get the funding year to year to do this? Not that the Food Policy Coalition is at risk of that. I'm just using that as an example, as one that I'm familiar with.
The one benefit of doing this regionally between the city and county is that these types of organizations can use that as leverage points to advocate for more funding and to sustain funding. So that is just one asset right out the bat. And we're not necessarily dependent on them. I'd like to kind of change that narrative, and that we're trying to create a more shared approach to doing this work. These are organizations that have largely already been operating at full scale, the model ones anyway, who we're saying, let's not change what you're doing, but maybe let's help do it in a different lens according to our priorities. So we're really trying to meet people where they are and really lift them up. And as for some of the newer organizations and coalitions that are coming together, that's where the Department of Health staff come in as huge resource assets to help them figure out how to plan, how to implement, how to collect data, how to even set that system up. And that way we are the resources for them. Of course, loss of funding could be, is risky, and it is present, but I guess we're operating with rose-colored glasses in a way that we hope that doesn't happen. But I think that because we have such a large constituency of partners, I could see us really mobilizing around an organization and supporting that work.
And we also create space for members of our partnership to come forward with asks to other partners, because we really want to leverage the collective power in the room. So one example is RIAC, the organization behind the Youth Workforce Development Group. They needed to acquire a large amount of funding over a very quick amount of time, so they extended the ask to our partners. And so that's also what the table provides, is we have nonprofits, for-profits, funders, large systems at the table. So it's that collective impact. We all need to be doing this work together. We're all invested in doing this work together. And so when a partner needs something, they have a table to make that ask. And we hope to continue to refine that process and bring in more funders, more philanthropists into this work, so that we have additional funding streams available. But a lot of the sort of for this partnership staff time does come out of the health departments right now, in partnership with our other community partners.
The only other thing I would add to that too is Craig mentioning the academic health department. So the work of our academic health department is focused on CHIP priorities, right? So that is also a really great arm that we hope to leverage even further to figure out how to think about sustainability. So we haven't cemented those plans or those logistics, but that's another added bonus too. It's a great lens with which to conduct the work for the region.
Thank you.
Alderwoman Rice.
Thank you. So I'm just really excited about this as well. I'm wondering how we can get the Think Health website added to the city's health department website, because at the moment I don't think it's there. I couldn't find it.
We have a long list.
Yeah, okay. A list of things to.
So they can basically just link it. Yeah.
Sure, right. Well, so I've just kind of been scanning through the website trying to find, listen, we all have our struggles with the website, so just highlighting that a little bit for us all. I think it's a great tool, and I do commend you all for the regional work and the cooperation. And so you have an Outlook system in the county and a Google system in the city. Is that what's happening? Okay, great. That's I feel like it's a hurdle we can overcome, but good to know that that's one of the holdups there. You know, and I do echo my colleagues' concerns about, you know, the community partners and what happens if they do fall through. But there is a robust group there, and there are so many organizations that are working in these fields and in the region that hopefully we've got some others that can step up and move in if one of those were to fall off. The youth violence one is of a particular interest, and especially having just passed the Cure Violence here, and I know talks are sort of beginning at a lower level in the county, or maybe a higher level in the county as far as participating in that type of an effort in the county as well, and housing that under public health, I think is the perfect place to do that because we are working regionally. So if you have any, I mean, do you have any updates on that or thoughts there?
Well, one thing that, that this partnership allows us to do is to convene members around a particular issue. So one example that really speaks to violence prevention is VPC has a really robust, comprehensive plan around violence prevention and reduction. They were seeing an opportunity to share that directly with hospital partners and sort of leverage hospitals to be a part of the work. And so under sort of the umbrella of the partnership, we're convening that meeting next month. So a large part in our role is conveners. So it's bringing together those folks that maybe see the same issue but from two different ends and need to be brought together to look for opportunities for alignment. So that's a lot of what we do, is sort of making those connections.
Awesome, that's great. And it, you know, when we were getting the presentations from Cure Violence, they talked about the rest of the network that is necessary to support this kind of work, and this is exactly the type of network. So these different pieces and these angles that we're coming at it is great. Also, the early childhood, those folks are moving full steam ahead at this point, and it's exciting. Last Friday to have their presentation as far as what they're working on with early childhood. So encourage my colleagues as well to engage with Southside Early Learning Center and what they're on there. And I'm sure that will be, that information will be provided. I believe it's a public report that they were.
Yes, it is.
Yeah, okay. Great. What have you present? Did you present at the? No. Okay, there was somebody else. Okay. They had it on a Friday morning, and so we couldn't participate because we were here. But so I'm very excited that this is a great way for us to be going forward together. And the more, I would encourage colleagues as well, the Think Health website is robust, and it goes through objectives and what all of these different focuses are working on. And how we can best support. So, I mean, I think at some point it would be great to have individual pieces come back and talk to the committee about what's going on and what we can be of use in. So I think this is a great overview for today, and hopefully we can do a little bit more deep dive on some of these things going forward.
That'd be great.
Mr. Chairman, do you have any questions?
I defer to Alderman.
I just had a follow-up and answer.
Sure.
You asked about the county working on Cure Violence, and I sent an email introducing Lori and Marcus to Winston Calvert with County Executive Page's office, and they're definitely interested.
Good. Great.
I have a couple of questions. Oh, excuse me, Jesse.
I don't have any
Alderman Todd, do you have any questions?
No.
Okay. Boy, I really have to get a lesson on going through this list and keeping on top of it. The funding for this is the Missouri Foundation for Health, or can you describe or walk us through who's paying for this work and how that's divided between the city and county and different?
So
I was going to ask about that.
State Health Department is a pass-through for some core funding for various initiatives at local health departments. And one of those is around core public health functions, which conducting assessment and improvement plan are 2 of the 10 essential services of public health. So we are funded through a grant, through our, regular budget to do this work. There's no external funding source for either health department to do this work. It's absorbed kind of into the operations.
Now, our position functions are rather new. So my position as the CHIP coordinator didn't exist several years ago. So that has been formalized, and we do have sort of formalized job description roles that have been sort of developed in the last couple of years. So that sort of designated staff time and hiring is new, but there's no new funding.
So in other words, the respective health departments are covering the coordinated effort here?
Yes.
Correct.
And is the coordinated effort sort of 50-50 city-county, or is it more population-based with the county having a significantly higher budget and a significantly larger population and a lot more tax base?
A great question. No, it's-
So areas
It's
where you
50-50.
see, it is 50-50. Areas where you see sort of, we take turns hosting things. So for instance, our event last month was hosted by the city because they had an amazing free space that we could utilize. So it's utilizing sort of the assets that we have collectively. Sometimes those are in the county, sometimes the city, sometimes those are with community partners.
Sure.
So it's really, it's 50-50, but we also lean on partners.
That's great. If there's anything we can do to encourage more significant participation by St. Louis County, just recognizing that you do have a bigger population, a larger tax base, and that sort of thing would be sort of helpful to the overall health of the region, recognizing that the city does have some health challenges that we alone can't address. I had some follow-up questions related to this street plan, and it was something that committee members were also sharing questions about. We have a much higher pedestrian fatality rate in the city of St. Louis than the national average. I think our pedestrian fatality rate is 3 times the national average. And so if you could expound a little bit on what you're doing to identify hotspots and what sort of direction you're taking in that regard, we would appreciate it.
This is a great example of working within the city government as an agency and really thinking about that health and all policies approach. So for the city aspect of this work, the county's already done a great job of this with their Complete Streets interdepartmental advisory team and having public health sit at the table for that, per my experience there. But here we're working with planning and our transportation policy coordinator, looking at data and then GIS mapping that with Metro by State to look at the 10 most dangerous intersections in the city as well as the 10 most dangerous intersections in the county. We have not fully developed the criteria on what that means, most dangerous. So we're group thinking through that and using what evidence is available to help us with that decision making. But right now, we're really in the planning phase of this and looking at what the data is telling us and then trying to figure out also if those intersections are near community hubs. If there are community-based assets that are around those intersections, then maybe those do get prioritized in terms of what kinds of interventions or initiatives, conversations, so on and so forth might need to happen to improve those intersections. So those are examples of how this work is kind of getting lifted off the ground right now with the intersections.
That's great. I would encourage you to reach out and connect to some community active advocates that are working on these issues. We know several of them and would love to help connect that resource. As well, I would encourage you to look at some of the policies and funding. The city, for example, really relies on aldermen to really improve its built environment by way of streets and sidewalks, which really does a disservice to an overall pedestrian health and mobility challenged access because we're not transportation experts, nor do we have enough funding to really adequately address those needs. And so highlighting that would be super helpful to us and helping provide some guidance as far as what we could be best doing as far as improving the built environment, especially for mobility challenged residents and being able to have access to the streets and policies as far as street closures and other things that we really are lacking in. So thank you for that.
Yeah, thank you.
Did that cover the questions you had, Alderman? Say that again? Is there a timeline on that effort?
We have been moving pretty swiftly around trying to identify the intersections. I would say it's October. I would imagine in the next couple of months we should at least have the data mapped and maybe even the criteria for how we're defining that. But I need to check with the internal work group to see for sure. We'll let you know.
Great, thank you. Mr. Chairman, do you have any more questions? Did you have any questions for this group?
Thank you. No, I just wanted to say, I think we've, our committee, as you can see, is always willing to help and do what we can. We really appreciate the partnership, you's working with St. Louis City and vice versa. And I'm sure we're going to be in touch more because, you know, I do have a very good committee here that's interested in doing what we need to get done for the residents. So, again, I just want to thank you personally and for taking the time to come down to everybody.
Thank you.
Madam Chairwoman and members of the committee, Vice Chairwoman, Chair. But when you're in that chair, that's who you are. So I did want to backtrack on one thing you talked when we were talking about STIR and we were talking about the stigma and so forth. There has been legislation that was presented last time in Jefferson City with regard to decriminalizing some issues with regard to HIV and some sexually transmitted diseases. That legislation, unfortunately, did not continue on that evidence-based track, and people tried to put things back in there. But there's an opportunity there as well to try to deal with those. That could be another report, obviously, to come back. There are a number of innovative things that our departments try to do with regard to sexually transmitted diseases. As you know, a lot of these same issues that we've talked about when we're talking about the equity issues, we're talking about the structural determinants of health, where you live, work, and play. All of these kind of things kind of lay themselves on each other and they impact each other in the same way. These issues are huge, and so when you bring in a lot of different people, people are looking at various aspects of this, and I think it's a healthy way to kind of look at these topics. And yes, we are absolutely happy to partner with legislative partners who are part of that local public health system to make sure that things are moving forward.
Alderwoman Rice, do you have a question on that?
Well, I just had a comment on the decriminalization of the HIV status. We did pass a resolution at the board supporting that, that legislation last year, and I went down and testified afterwards on that. Unfortunately, neither bill went anywhere, but hopefully they're going to continue that effort. So this body is supportive of that work as well.
Yeah, thank you.
Absolutely. And I would just like to point out one additional health concern that wasn't listed here that I really think is of
Cover everything.
paramount importance to our city, and that is lead exposure. We continue to have extremely high pockets of extremely high lead exposure in our city. The 20th ward happens to be the highest rate. This is an issue that impacts our children, and one that carries throughout an entire lifetime and does irreparable damage to our most vulnerable citizens, our children. So,
right, and she's going to talk about that. I did want to point out this was about
and I want to make sure we're
specifically about a few partnerships. That's what
Sure.
today.
Yep. Thank you.
Yes, so as Hannah mentioned, the CHIP is living and breathing and iterating. And so one of the opportunities that will be surfacing is another collaborative effort between the Department of Health and the city, and then St. Louis County Department of Public Health, around resurfacing a Healthy Homes Coalition. So Healthy Homes being the crux of the coalition, but then also being able to look at lead and asthma. As we know, those disparity rates are extremely high among both, asthma especially. And so that also involves our hospital partners as well, and thinking about asthma referrals and other pieces. And we have been looking internally at our own lead program, you know, actually establishing SOPs, standard operating procedures, and really taking a deep dive. That Bureau has new dedicated leadership, and so that is on the table, and we can share more about that as it unfolds. But we can also share with you our Healthy Homes invite on October 22nd. So we're moving that work forward.
Please do share that invite. I think, I know I would particularly like to participate. You know, as it pertains to the lead testing, we have huge gaps in who we're actually testing, and those big gaps happen to be in areas of low income, and areas that tend to have high rates. Those gaps, particularly in under 2 to 3 years old, where the lead exposure does the most damage and is often underreported.
Yes. We've seen that
in daycares and other
50%
things. Absolutely.
testing over the period of time, so we
Huge
know.
gaps.
Yeah, we
Huge
know
gaps.
that there's opportunity, and then there's also the overlap with vacancy issue too. So
Great.
we're sitting at that table as well.
Great, thank you so much. Thank you for your time today. We'll try to get out where we can all still have something to eat for lunch to keep our own health in check. Yes, all right. Mr. Chairman, would you like to, do you mind if we adjourn?
No.
With that, I'll take a motion to adjourn the Health Committee.
I move to adjourn Health Committee.
Do we have a second on that motion to adjourn? Thank you.
Previous row.
With no objections, we are adjourned.